When we look at the second-line treatment choices that we have available, it of course depends on what we did in first line. We would switch chemotherapies out from oxaliplatin to irinotecan-based therapy if we have clear evidence of progression oxaliplatin, and vice versa. And we could continue bevacizumab or VEGF inhibitors beyond progression or switch to an EGF receptor antibody. So second-line choices clearly depend on first-line treatments and, of course, on biological parameters, molecular parameters, like, for instance, BRAF mutation testing. For the BRAF V600E mutant tumors, which are a very specific group, 8 to 10% of patients, we have second-line data now that a completely biologically oriented treatment approach with a combination of an EGF receptor inhibitor and a BRAF inhibitor like regorafenib, that those patients actually benefit from a biologic approach more than from second-line chemotherapy. So it really depends on first-line treatment and molecular parameters, what we'd like to do in second line, and of course the idea of immunotherapy comes into play for the patient with MSI-high tumors. When we talk about moving from one line or one treatment to another, the factors that come into play are clearly tumor progression, relevant tumor progression. Sometimes I observe kind of smoldering progression on maintenance therapy, which is not clinically relevant, so I might keep patients on maintenance therapy. But if we see clinically relevant progression, which is not clearly fully defined what that is, because sometimes we don't necessarily use RECIST criteria in clinical practice to talk about clinically relevant progression, then we switch treatment. So clinically relevant progression, plus if patients don't tolerate treatment. There are patients who cannot tolerate oxaliplatin-based therapy. Hypersensitivities, for instance, with oxaliplatin could trigger a change in therapy to irinotecan-based therapy, et cetera. So it really depends on toxicity and progression of disease that triggers switching to a different regimen. When we talk about sequencing of agents and we go along the lines of EGF receptor antibodies versus later line therapies like regorafenib and TAS-102, there's a recent very interesting study which we're still struggling to understand, the reverse study from Japan, which looked at in a RAS or KRAS wild-type tumor population, should you give EGF receptor antibodies plus irinotecan first before regorafenib, or regorafenib first before EGF receptor antibodies. And the study was a sequential study, randomized comparison, and had a very surprising result that there was a 6 months benefit in overall survival for the earlier use of regorafenib, meaning regorafenib before EGF receptor antibodies. We still don't know exactly why that is. There's one hypothesis that the earlier use of EGF receptor antibodies induces resistance mechanisms in cancer cells, meaning we see the emergence of RAS mutant clones, and that's actually something we can test with circulating tumor DNA nowadays. And these RAS mutant clones, which are kind of selected under the pressure of an EGF receptor antibody, could drive, let's say, more aggressive biology. And when we use EGF receptor antibodies in a later line of therapy, this might actually not be as important because, the duration of therapy at that point is shorter. So we're still struggling with the idea, how to best sequence these drugs. I personally, in my clinical practice, have not yet embraced kind of reverse sequence. I use EGF receptor antibodies in RAS wild-type, BRAF wild-type, left-sided tumors before I use regorafenib.